Okay, while we're continuing on with Gero syndrome, falls in the adults is a big one. In this chapter and throughout the extra activities I have on there for you, we really have to start evaluating more closely what we can do to prevent falls. We need to look at intrinsic and extrinsic factors. We have to have appropriate fall risk assessment in place and individualize them to that client. We need to look again at those medications, and I'm not going to spend a lot of time on this here because you have done that with polypharmacy as one of the Gero syndromes. And again, we always want non-restraint interventions as possible. Key terms are not new. We just have to be more aware. And what I find interesting out of home care is if you're going to do a home assessment and people know you're coming, they will clean up, get those floor rugs out of the way, and the minute you leave, they're back in. And sometimes it's good to kind of surprise if you can, which again, you're going into their personal space. Falls are preventable. The problem is they are life-threatening because of decreased reflexes, inability to break or stop their fall. Heads are often hit. If we look at the older client, looking at medications they're on does become a big issue. Even that aspirin, the risk for bleeding. It is not a normal consequence of aging. It really is part of the geriatric syndromes. We see a frequency increases the more frail that client is. And it usually is stemming from an acute problem or chronic disease. If you have COPD, maybe you aren't walking as strongly, as well, as far. Your risks just become much higher. And the more you sit down, the more risk you are for orthostatic issues. What is amazing that every client is supposed to be on a falls risk and identified, and we do this so well, but yet 50% of these clients that fall in a hospitalized setting are still injured, and it's still averaging 3 to 5 falls per 1,000 bed days. 1 million inpatient falls a year. That's just overwhelming numbers because again, these are reportable statistics. Another great place to go to get data and when you're looking at trends and things is the National Database of Nursing Quality Indicators. And as hospitals are accredited and nursing is looked at, this is a measure of quality and safety is the number of falls. And in the nursing home setting, it's even more detrimental because as people fall, they will lose Medicare funding, and we can't afford that either. Up to 30% moderate to severe injuries, up to 20% fractures. And again, that importance of health promotion is strong bones. Exercising, keeping that calcium being reuptake to the bone. The more that people fall, the more deficits, further hospitalizations, and death. And what a staggering number that the cost of falls in 6 years could be up to $55 million or billion dollars. That's just staggering, the prices of this. So as nurses, we really need to be more proactive. Risk factors, again, intrinsic, related to their physiology and physical changes. What's going on with that person? And extrinsic is that physical environment, making sure that things are safe, lighting, looking at their visual acuity, those shadows on the wall, depth perceptions that can change. There are numerous fall risk assessments out there, but it is imperative that it is done. I just see too many nurses not looking closely at medications that were changed that day or how fatigued that person is compared to 24 hours ago. Those all become changes in risk factors. You know, even a simple as the heart rate has been normal, maybe they've gone into a little AFib and now it's irregular, even though they're asymptomatic. That's a trigger in itself. With this fall risk assessment, we have a lot of fall prevention. And if there's anything I'm begging you to look at, is go out and look at stepping on, stepping up. That I have out there for you is a direct link. This came out of Australia. It is hit the United States running. Most nursing homes in our area are doing this, and it is just phenomenal. This stepping on program for fall prevention when followed appropriately. So we look at those intrinsic or internal factors of age, gender, race, cognitive function, disease states, and more importantly, those medications that people are on. The extrinsic factors that we see are those environmental hazards, not wearing the appropriate shoe wear. Anybody who's been in a recent hospitalization, homeostatic wise, they're just off, and that in itself increases a risk. Watching people inappropriately use canes, wheelchairs, and walkers. It's not reckless use, it's really inappropriate use, not using it the way they're trained. So again, as we look at this assessment, look at that basic functional status. Can they use it? One of the big things is we rely too much on physical therapy, although detrimental to our practice. We still, as nurses, need to be ongoing evaluation if our clients are using their walkers correctly, their canes correctly. Even if they just have that subtle fear of falling, that's enough to get them to stop too quickly and fall. Again, it's that physical therapist we rely on for that evaluation and to help us, and the occupational therapist for more of the ADL lighting and the needs that they will need for that safe environment. There are wonderful exercise programs out there. A lot of chair strengthening, Tai Chi, things to keep those muscles more flexible and mobility at its utmost. Regular eye exams. This is another thing when people are losing money. Good thing under Medicare there is a benefit for that. But making sure that yearly they are screened. Any cardiovascular condition, postural hypotension, those people that just sit all day, their diuretic kicks in, and they have to get up too quickly to go to the bathroom, down they go. Excuse me. The importance of calcium and vitamin D so we don't get that bone demineralization. Again, not going to spend a lot of time on medications here because we had that whole unit on polypharmacy as part of the geriatric syndromes. But again, understanding that Beers criteria and how certain medications and doses with this population increase that risk for falls. We always want to start at the lowest dose, give it time to work, and change as necessary. Discontinuing any pills that don't need to be needed, and looking specifically medications that client was on when they fell, if they fell, because that in itself could be a trigger. If you'll notice on some of these, we may just need to get a lab value drawn just to see if they have an electrolyte imbalance or their level isn't in the range it should be. Again, wonderful resources out there. In Wisconsin, we are really focusing on stepping on, that we are doing things in the same way so that when we transition from one area to another, we are using the same resources and the same tools for prevention. Incident reports in the acute care settings level what's going to happen. So we have to report falls on our incident reports, obviously, but then that data is collected, and that the nursing quality indicators will rank this from a none to a death. So it's a five different scales where we look at those injuries. And again, this is from the acute care setting. So again, we have national organizations that have given us excellent tools. Fall risk assessment should be done throughout every shift. It shouldn't just be a once every 24 hours. People's condition changes on the PM shift, the night shift. We have to stay more on top. While we have them in place, we are not using them to the best of their ability. Obviously, by reducing falls, we'll save healthcare dollars, and really looking at the environment and many factors in our assessment to keep our clients safe.